Welcome to our lecture today. I am so pleased that you decided to join us. We are going to talk about asthma. And in fact, we're going to talk about some other diseases as well related to the respiratory system. But we're going to start with this one because I think that there are a lot of things we will find as we look at some of the other airway diseases that they have some things in common, okay? And so asthma is a chronic inflammatory disorder of the airways. And in this first image here, we can see in the normal lung, we have the relaxed muscles around the tubes that help us breathe, and we have a normal lining and a normal amount of mucus production. But in the asthmatic lung, we can see that the muscles around our breathing tubes are tightened. We can see that the lining of the tube is swollen, and when that happens, that makes the diameter of the tube smaller, so it's harder for the air to move through. And then we also see some excess mucus production, which adds further difficulty for gas exchange to happen. And so we're going to talk a little bit more about this in detail. And so like we said, asthma is a chronic inflammatory disorder of the airways. It affects people of all ages, men and women. Children have asthma, adults have asthma, older adults have asthma. So it's a problem that is definitely part of what we encounter in nursing quite frequently. So again, here we see the normal lung where we've got our airways are relaxed and open. And in our asthmatic lung, we can see that we've got muscle tightening, swollen linings, and excess mucus. So those are three hallmarks of this disease that are going to be important to remember. So I wanted to kind of start out by talking a little bit about mast cells. So mast cells, leukotriene and histamine release, all add and contribute to the problem for people with asthma. So leukotriene, D4 releases by the mast cells. This is a major problem for asthma. And histamine release by the mast cells during an allergic reaction is also a major problem. Why? Because these things cause bronchoconstriction, right? So constriction of the bronchioles or the airways, the breathing tubes, and also fluid production or mucus production, okay? And so narrowing of the airways in asthma is part of the problem. And again, we can see here the air gets trapped in the alveoli, and because of these tightened smooth muscles around the bronchus. And so we've got a wall that's inflamed and thickened. And then when you add that excess fluid or mucus to the equation, you have poor gas exchange. And we're going to study exactly what we mean by that here in a minute. So why does this narrowing of the airways happen? So it happens for several different reasons, right? One we just talked about, which was the histamine release, right? Histamine release from the mast cells and leukotrienes. And also, there are certain medications that can actually cause problems with our asthmatics. We should not be giving antihypertensive beta blockers to patients with asthma, all right? So these are beta-2 receptor blockers, and what they cause in the lungs is bronchoconstriction, all right? So it's important to remember that asthmatics should not have beta 2 receptor blocking drugs like metoprolol. Now, this is where it kind of shows this kind of opposite end of the spectrum. Opening our airways in asthma, okay, we want to activate the beta receptors to get this opposite effect on the lungs. So people get confused about this all the time. So albuterol inhaler, okay, it is also a beta receptor drug. However, it activates the beta receptors, and this allows for bronchodilation of our airways, which is what we want to happen in the case of asthma. So, this bronchospasm, coughing, and wheezing all is a result of these triggers that cause this kind of allergic response, okay? I want you to notice something about the picture here. It says wrong, wrong, right. What is this referring to? Why is the gal coughing into the air not doing it correctly? Because she's spreading potential germs all over the room and into the air. And also the second image where she's coughing into her hand. Not such a good idea anymore. Why? Because even though she's not coughing out into the air, she is coughing into her hands, which will then be covered in germs. Nowadays, we try to educate our patients and we try to remember to cough into our elbow. So that's something for you to remember. That's something important for us to be teaching to our patients as well. So what are some of the assessment findings in a patient who is suffering from an asthma exacerbation? We might see dyspnea, which is a report that the patient gives that says, I cannot catch my breath. It's subjective because it's coming from the patient. Chest tightness. So the patient might say to you, my chest feels tight. So this is another subjective observation made by the nurse, and these are based on statements that the patient makes. They may also tell you that they feel scared. So anxiety is another observation that you might make. I mean, objectively, the nurse can identify that the patient is coughing. You can put your stethoscope up against their lungs and listen for wheezing. Mucus production may be present and they may be able to cough something up. Or you may observe them using their accessory muscles to breathe. And if you look at the picture of our gentleman over here, we can see that his collarbones are very well pronounced, and we can actually see his rib bones because he's breathing in so deeply that he's using his accessory muscles to get air in, and it's not going in, right, because of these tightened airways and this mucus production. And so one of the hallmark signs that somebody is having a pretty severe asthma attack is that they look like this gentleman right here. So we want to remember that when a mast cell is activated by a trigger, okay, these granules release many mediators, which are chemicals that mediate reactions leading to the symptoms that we see in asthma, all right? And we're going to see this over and over again. Also, a low O2 saturation. So we can always check our patient's O2 sat with a pulse ox and see if they have a good pulse ox. What would be a good pulse ox for a patient, for a normal patient, just sitting, resting comfortably in the bed? What do we want it to be above? I'm going to give you a second to think about that. We've studied this a few times. We want their O2 sat to be above 95%, okay, 95%. Once it drops below 94, once it gets to 94% or below, then we are concerned and we must find out what's going on with the patient, which requires assessment, okay? So, what happens when you have asthma, okay? And so, one more time here, we're going to say muscles tighten, airways swell, mucus clogs the airways, and lungs have difficulty moving air in and out. So, I've mentioned poor gas exchange a couple of times. And what we need to understand is what's happening at the cellular level. All right? So we talked about this histamine release, and we talked about these chemicals that kind of trigger leading to symptoms. And we said that one of these symptoms was that the patient would be coughing or that the patient would be short of breath. And this is due to bronchospasm. Okay? This is a clinical manifestation of asthma resulting in this coughing, this wheezing, and this poor gas exchange. And so when we look at the lungs, we look at the bronchus, the bronchioles, all the way down to the very ends, we see the alveoli. And at the alveoli, that is the level where gas exchange occurs. Okay? And we know that blood comes in from the body, venous return. It goes through the lungs to get reoxygenated, right? The other thing that happens is that CO2 is removed. So if we don't have that happening, then what we've got is poor gas exchange. Remember earlier we looked at what happens when these bronchioles are, the diameter has been made smaller, right? Through this bronchospasm and through this constriction, what happens is that air gets trapped in these alveoli. And if the air is trapped in there, then it's not doing its job, where it's flowing back and forth across the gradient that you see here, and pulling in new, fresh oxygen for our red blood cells and getting rid of that carbon dioxide. So that's really what's happening when we have a problem with gas exchange at the cellular level. So we talked about triggers. Now, triggers are these things that make the asthma symptoms worse. And people with asthma, they have different triggers. It's not the same for everyone, but it's really important to be able to identify what your triggers are so that you can keep your asthma under control. You either want to try to avoid the triggers, or there are some medications that you can take in advance when you know you might be exposed to some triggers, okay? So outdoor triggers include the weather, the air quality, pollen. People typically will have allergy seasons where every spring or every fall, their allergies get triggered, their asthma gets triggered. And so you want to be able to do things like pay attention to the radio and the news reports. Maybe you have a website that you can go to where you can review what the air quality is, what the pollen count is, right? If that makes sense. And it can be helpful in planning your day so that you don't run into troubles with your asthma. And so definitely staying away from wildfires. We see them more and more now. Avoiding smoke or some kind of vapor. When it's cold, wear a scarf or a face mask that covers your nose and mouth. We want to keep that airflow as warm as possible. So there are also some indoor triggers, right? Dust, mites, cockroaches, rodents, mold, pets. These are all types of indoor triggers. Air purifiers in the home can be helpful. HEPA filters especially. Really high-end vacuum cleaners that keep the home as clean as possible. This can be helpful. Some people have to wear a dust mask while they clean and do other activities of daily living when they know that they're going to be exposed to their triggers, okay? Even washing the pet regularly can sometimes help. And also remembering that even humidity levels in your home can have an impact. We want to keep the humidity level low, around 30 to 50%. Wash bedding every week, make sure we dry it completely, and allergy-proof pillows, things like that. Mattress covers, right, can all help. Other indoor triggers we've already mentioned, kind of like cockroaches, mice, rats, mold, humidity, smoke, different sprays and scents and disinfectants that we might spray in the house can be huge triggers. So we just want to make sure that we identify what those are and then we are avoiding them. Because if you do that, you can really get to a point where you're functioning a lot better, maybe with a lot less need for medication. Although pretty soon here we're going to talk about medications and how important they are for managing asthma. Other common triggers include illness. So for example, if you think you are getting a cold or the flu, you may want to contact your healthcare provider and be seen. Severe allergies, sinus infections, these can all be things that make it harder for you to breathe, and so we want to be aware of that. You know, emotions can also trigger asthma attacks. We want to talk to our doctors if anxiety or stress or other emotions we are noticing make our asthma worse. Because there might be some medications that we can take when we know that we're going to be triggered in terms of our emotional stress that can help relieve those triggers for asthma, okay? So these are all important things that we want to discuss with our healthcare provider. So, how do we know whether or not we are having problems with our asthma? Well, number one, we're always going to know if we're having problems if we start sneezing, coughing, wheezing, feel short of breath. Well, those are obvious signs to us, right? And something we're going to spend the next few slides talking about is something called an asthma action plan. This is something that you as nurses will work with the physicians and other providers and the patients on to tailor a plan for them in the case that they get an asthma exacerbation. So in other words, we're going to be discussing the zones. And you can see here from this slide, we've got just our green zone, which is just kind of our normal routine and the things that we do to keep our asthma in check. Our yellow zone, when things start to become a problem, when we start having symptoms in our asthma, and our red zone, when it's probably time to either call 911 or go to the nearest emergency room. So what you see here is a peak flow meter. Now, the size of the peak flow meter is important in terms of it being a younger child or an older child or an adult. So you have to make sure you're using the right size. And you have to make sure that you're using it correctly. You want to take a deep breath and you want to blow hard and fast into the meter and then record the number that's indicated by the marker, right? And you want to repeat that twice, okay? So you might do it a total of 3 times and you want to record the best score. So let's take an example, okay? The average score for a healthy 10-year-old female is about 254 liters per minute, okay? So that's the best score. And so in her green zone, she would be 80% of her best score. So 80% of 254 is 203 or higher, Okay, she's still in the green zone. Yellow zone is 50 to 80% of your best score. So that's around 127 to 203. Now we're like, well, we're in the yellow zone. We're going to have to add some additional medications to get this asthma under control. And in the red zone, we are at 50% of our best score or lower, and that would be 127. So if you blew into the peak flow meter and you got a score of 127 when your best is 254, you are now in the red zone. So this is another way that we can identify how severe our asthma has become. So in our green zone, we feel well. We want to be here every day, okay? This means we have no signs of asthma. We can do our usual activities. We're sleeping without having symptoms. And I wrote in here that our peak flow meter was at 254. However, when we have asthma, we are taking medications, right? These are maintenance medications. So for example, you might be on Flovent, 2 puffs a day. You might be on Singulair, 10 milligrams once a day. And then you might have an order for an Intal inhaler. And this would be to take 2 puffs before exercise, okay? So that might be just like your maintenance routine. So let's take a look at those medications here. We can see that Flovent inhaler. We can see that Singulair, which would be maybe a chewable medication if this was for a child. And then we can also see our Intal inhaler. What we want to know about that in particular is that that is a mast cell stabilizer, all right? And what that means is if we can stabilize the mast cells before a known event, we can prevent that histamine release, okay? But these are only really useful before we engage in the activity, all right? So a medication like this isn't going to help us once histamine has already been released and now we're actively having symptoms, okay? So we can use our inhaled corticosteroid like our Flovent daily and our Singulair, which is going to help us as well daily as routine meds. Now symptoms are present, okay? So we've done our daily routine meds and something has triggered, okay? Something that's triggered and our peak flow now is around 203. So you might have mild or moderate signs of asthma in this phase, in this zone. You could include, this could include some coughing, maybe some wheezing, feeling short of breath, some tightness in the chest. These symptoms might keep you from a usual activity or be so uncomfortable that you're unable to sleep. And if this happens, we're going into yellow zone, right? So for our asthma action plan, now we're in the yellow zone and we are going to be using a quick relief medication or a rescue medication like albuterol. Now, albuterol was what we talked about earlier in the lecture when we talked about that beta receptor getting activated, right? If we activate that beta receptor, what's going to happen to our airways? They're going to open up, right? So that's what the albuterol does for us. So 2 puffs every 20 minutes, up to 3 times. We can do that, okay? And we want to wait, and we want to see how we do. If you do not return to the green zone after an hour, right, then we need to figure out whether or not the situation is getting worse, staying the same, or getting better, all right? We want to keep monitoring to be sure that you're staying in the green zone. So this is what it would look like. In this phase, we've got our either our albuterol inhaler, right? And this is our quick relief of bronchospasms, we can use this short-acting beta-2 agonist, albuterol, or we could use our nebulizer. Our nebulizer is like our kid we see down here with the mask on, and we see the mist that has the medication in it that he's breathing in, which is the same medication. It's albuterol in both cases. It's just a matter of delivery, whether you're using it with an inhaler or whether you're using it through the nebulizer machine. So that's where we are at this stage. So we're either going to, get better, kind of stay stable here, or worse. That's what we're checking for. Well, what we identified is that these interventions are not working. So we tried the albuterol inhaler. We went ahead and followed the directives on there. And we did not get back into the green zone after an hour, okay? So now we're moving into the next level. We're starting to go into red zone. And when we go into red zone, sometimes you might see an order on the asthma action plan for Combivent, which is a combination drug, and it might call for 4 puffs of this medication along with an oral steroid. So perhaps it would be like 30 milligrams of prednisone, and maybe you would take that for 4 days. So this could be the next step that you would take if you were no longer in the yellow zone and you were heading into the red zone. So if we are not stabilizing at this step, if we're not going into the green zone now that we've taken our Combivent, our 4 puffs, and our prednisone, our 30 milligrams, then we may need to go to the red zone, all right? Now, how are we going to know, right? We're going to know because now that we've tried these interventions, our symptoms are not improving. In fact, they're getting worse. And maybe even our score when we blow into our spirometer has gotten worse, okay? One of the things that it's important to mention, though, at this point in the lecture is that when we use steroids in our patients, they must be tapered. And what that means is we slowly decrease the steroid dosage over time. So for example, if you were ordered to take a 30 milligram dose, something else the physician might order on this would be a steroid taper that looks something like this. Prednisone, 10 milligram tabs. Take 30 milligrams by mouth on the first day, all right? And then you might taper it by 10 milligrams on day 2 and down another 10 milligrams on day 3. And so what that does is it decreases the amount of steroid that you're getting over the 3-day period. We are going to explain why that is necessary in another lecture. But just for now, it's important for you to know that tapering steroids is an important, safe way for us to prescribe these drugs and help our patients understand the proper use of them, okay? So, here we go. We're getting worse. This is an emergency. Your asthma is seriously out of control. Signs include fast, shallow breathing, a very tight chest. You're having trouble, you're wheezing loudly, you're really starting to feel apprehensive, this feeling of impending doom. Your peak flow is below 127. You really need to take next steps. So this is a very short of breath person. The quick relief medications have not helped. Your symptoms are the same or worse. after 24 hours in the yellow zone, and if you cannot do your usual activities, it's going to be time to call the physician. So at this point, your asthma action plan might indicate that you could do 8 puffs of an albuterol inhaler or use your nebulizer treatment. You could repeat this every 10 minutes up to 3 times, and you might take a dose of prednisone. It's about 40 milligrams, and then if you're still in the red zone, it's going to be time to call 911. Okay? And so I hope that this was helpful for you to kind of see how we might use an asthma action plan. An asthma action plan needs to be worked on with the physician and the nurse and the patient and the family. And then it probably needs to be adjusted over time to figure out what works and what doesn't. But I thought it would be interesting and fun for us to learn by looking at one and watching it play out over time. So this is a video that I have of an adolescent actually having an asthma attack in the emergency room. And I think it's important for us to watch this video. And you'll be able to see some of the signs, the symptoms that we've discussed, and it even kind of shows you what's going on the inside of the airways so that you can get a better idea of what this looks like in real life.
15-year-old Chris is having a severe asthma attack. His immune system has made what could be a fatal mistake and is shutting down his airways. Without help from the medical team, Chris's body may shut down completely.
You're not going to die. You're not going to die. You'll be okay.
The breathing tubes in Chris's chest are squeezing tightly shut and filling with sticky mucus, blocking his vital oxygen supply. If he's not treated soon, he will die.
This is a really life-threatening episode of asthma. Asthma is pretty common in our community, and most of the time it's not this life-threatening, but this one is quite serious.
Chris's allergic reaction has tricked his immune system into shutting down his airways, blocking vital oxygen to the rest of his body. The drugs are supposed to help the muscles around Chris's airways to relax, but there is a problem. The mucus stops the drugs from reaching his blood supply.
Through the vein to try and help it out, because sometimes the lungs close down too much for this stuff to work.
Time is running out. Chris's body takes emergency action. His shoulders and neck muscles swing into action to help inflate his lungs. But even this is not working. As the pressure mounts, the team must find a treatment to get the drugs past the mucus. Chris is by no means an isolated case. 1 in 9 Australian children suffer from asthma. But for Chris, the situation is looking dangerous.
Chris is currently having Ventolin or salbutamol through a nebulizer, which he's breathing into his lungs. This acts on the muscles around the small airways and helps to open them up. Unfortunately, sometimes when the airways are very closed down, the salbutamol doesn't reach the areas that it needs to get to. The inhaled Ventolin is not working, then we often will go to a different form of medication. Again, a relaxant for the muscles around the small airways, and it helps to open those airways up, and it's given as a one-off dose over about 10-15 minutes in severe asthma.
Inside Chris's body, the airways start to open as the drugs take effect. Air finally returns to Chris's lungs, inflating the 300 million tiny air sacs.
Chris, feeling a bit better?
At last, he can breathe.
Chris seems to be feeling a lot better now. The intravenous medications seem to have taken effect. He still is very tired because he's been working very hard with his breathing, but we're a lot happier with his clinical progress now.
Chris was admitted to intensive care for 3 days, with a further 3 days in a medical ward before being sent home. He is now back at school playing soccer and is aware that it is important to look after his asthma and to tell his teachers and family when he's not well. Chris had always expected other people to look after his asthma, but after this emergency, he now understands that he must recognise when he is having asthma and follow his asthma action plan.
So you can see after watching this video how scary this must have been for this young man. Notice how calm the staff remained, that even though he was struggling to breathe, they were very calm in getting him IV access and in giving him medications through his IVs, steroid medications, directly into his bloodstream to help him start to breathe better. And so here's the thing. When you are having an asthma attack like you saw in the video, because of the mucus production, right, all of the inhaled medications aren't really getting to where they need to go, right? So because of the mucus production and the airways tightening up so much, you can inhale an inhaler or you can do a duoneb treatment and it is not going to get where it needs to go, right? The medication is not going to get where it needs to go. What you need at this point is a major decrease in the inflammatory response, which is why IV steroids are going to be our best option to get him to a point where we can get some of these other medications to actually be helpful, okay? So for teaching our patients with asthma, we want to teach them about the signs and symptoms. That wheezing is a scratchy or more of like a whistling sound when breathing. Shortness of breath or rapid breathing can occur and be associated with exercise. Chest tightness or pain. Fatigue is another sign. Sometimes people will stop playing a game or they'll avoid activities. Coughing can be continual. It can happen often. It can be worse by cold air. There might be problems with sleeping at night due to coughing. So other symptoms that can happen, a hoarse voice, pains or cramping, diarrhea, hives or swelling, nausea or vomiting, dizziness or fainting, tightness of the throat, abdominal pain, and like we mentioned before, a feeling of doom, apprehension, confusion, right? Because if our brain is not getting oxygen, we could easily become confused. The other thing that's important about teaching our patients with asthma is about the use of the equipment. So here we can see several different types of equipment. We've talked about the peak flow meter. We've talked about the inhaler and the duoneb treatment that we see down there with the mist. What we can also see here is an Advair discus. That's a steroid inhaler. That's a disc. We can also see our spacer. Spacers are often used with inhalers to kind of help with getting the medication into the lungs. If the patient uses an inhaler with a spacer properly, it increases the amount of medication that gets into the lungs where we want it to go. Another thing we need to remember about teaching our patients is that after they take an oral steroid inhaler, we want them to swish around some water in their mouth and spit it out to prevent thrush. So here you can see a little boy rinsing out his mouth after he has had his inhaler, his steroid inhaler, to prevent a candida infection. Okay, and this is what it looks like if you look down in that lower image right there. The tongue is all white. This can be very itchy, painful, irritating. We want to prevent this. Because the steroid decreases inflammation, it also has a tendency to decrease our immunity, meaning that something like thrush that normally lives in our mouth that doesn't thrive could thrive once oral steroids are used, and there's like a localized decrease in their immunity, and then the thrush can bloom. So we also want to teach them about their asthma action plan. That's what we just went over piece by piece. Here you can see it in one form. We see the green zone, the yellow zone, the red zone, and we need to make sure that they understand the directions. Other things that we want to teach our asthma patients are to avoid those triggers. Find out what they are and avoid them. The other thing we want to teach them to do is to plan ahead when they know the trigger will be encountered. And we talked about that Intol inhaler, that mast cell stabilizer, which helps them be prepared for being exposed to the things that trigger their asthma. So, that is all I have in our discussion regarding asthma today. I hope that you learned something. I hope that you'll be able to take this information and use it to teach your patients in the clinical setting. I appreciate your attention, and I hope you have a great day. Aloha.